I would like to welcome you to this, our Impact Research Group's third webinar series. Today, my colleagues Carrie Jackson, Kim Manley will be walking us through wrapping capabilities around citizens and service users, challenges and opportunities. So it's very much a co-inquiry with participants, and my other colleague, Jonathan Webster, and I will be keeping an eye on the chat function. So as Kim and Carrie are presenting, if you've got any questions, drop them into the chat. And then if there's time towards the end for questions, we can raise that with the presenters. Otherwise, again, we will try and address your comments if time is of the essence, because we've lost 10 minutes. So again, apologies. Welcome, and I would like to hand over now to Kim and Carrie. Thank you.
Thanks very much. I could just ask everyone who's joined us just to turn your cameras off, please. That would be great. And just make sure you're muted. And then there's opportunity to ask questions at the end. Bianca, we'll have the next slide, please. It's great that you could join Kim and I today. We're going to be illustrating how to wrap capabilities around citizens and the workforce using 4 case studies. So the first is a case study from urgent and emergency care. The second is a rheumatology services using tiers of care based on local commissioning and 13 clinical groups. The third is some work that we've just completed with Marie Curie UK across the 4 countries. And the fourth is the iCare workforce project that we're working on in collaboration with colleagues across the east of England. Next slide, please. So the context for this work is very much driven by the workforce. So the priority for systems transformation and workforce development to meet health and social care needs, the priority for retention, growth and career development of the workforce and staff well-being, particularly in the light of the challenges of the global pandemic, the importance of putting citizens and populations at the heart of what we do in terms of wrapping workforce capabilities and impact around their needs, rather than the professional siloed approach of just wrapping capabilities around independent professions. And that very much at the heart of that is an asset-based approach to building on citizens' strengths, so that we focus more on what matters to them in terms of their health and well-being and the priorities that enable them to have services that are designed around their needs. Critical to all of this is using the workplace as the main resource for learning, development, improvement, knowledge exchange and inquiry. And that's really critical because with the staff shortages that we have across our workforce, it's no longer possible to release people to go to programs. And we're increasingly being asked to commission programs of learning that focus on the workplace to enable people to learn in real time. And finally, there's a real need to develop the collective leadership capacity of our workforce so that we're developing the potential for leaders across the entire workforce, regardless of whether they're registered or unregistered in all health and care contexts. So I'm going to hand over now to Kim. Thank you.
Thank you, Carrie. And the next slide, please. Thank you. So this is a very unusual approach to developing the workforce compared with what's been done in the past, and so it is complex, and I would like to share with you some of our assumptions which we're bringing to the fore, some of which have been suggested by Carrie. So the assumptions that we're thinking about here is we're not looking at the skill mix that we require, the number of staff from different professions. We're trying to look at issues of capability that is required, regardless of who is bringing that capability. We're no longer talking about substitution for medicine or other roles, but shared capabilities across all of our professions. But we're not talking about generic workers. We're not saying we want just one set of generic workers. We recognise, as Carrie mentioned through collective leadership, that each of our professions brings different skills and different values, and if they complement each other, then we'll have something that's much more holistic and enables all our professions and staff to really work to the top of their license. And that is also about using unregistered staff appropriately. Our approach is aiming to reduce duplication, and in our previous silos, of secondary care, primary care, tertiary care, and charities, we're seeing lots of duplications of things happening, and that just wastes our resources and doesn't enable us to use them effectively. We're trying to focus on continuity across the system, not just within a hospital stay. And we want to get the right person at the right time, as near to home as possible, to be providing the capabilities required to meet people's health and social care needs. So the role of community as the first contact and triage is really, really important. So those assumptions are the basis of our approach, which I think some of you may find challenging. So we want you to think about what those challenges are like. We've experienced some of those challenges, and things are getting a little bit better now with the new structures that are happening over the next month. So the next slide defines for us what we mean by capability. So there's a move away from competencies to capability, and there are different models of competencies, and you see all the different spellings in the papers that don't necessarily align with the different models, but competencies does tend to have a technical connotation, not always, but it can be, whereas capability is understood to be much more about growing and enabling people. So capabilities are the attributes, which are the skills, knowledge and behaviours which individuals bring to the workplace. And they include the ability to manage change, be flexible, deal with situations which may be complex or unpredictable, and continue to improve performance. And that definition has been agreed through Health Education England with many of the key stakeholders in health and social care. The next slide then identifies the principles that we've been trying to work with, sometimes successfully, sometimes they've been difficult. So first of all then, that explicit capabilities do enable role clarity and clear expectations, and those are required for us all to work effectively, but it does not guarantee that they are adopted. Whether these capabilities are adopted depends on how they're used, whether there are facilitators in the workplace to enable learning, and whether there's a learning culture in the workplace and across the organisation and across the system. And this has been a theme of our webinars, is the importance of creating a learning culture across the system at every level, if we really want those capabilities to be experienced in practice. The need to focus on the patient pathway across the system from a multi-professional perspective, everybody's contribution, how they complement each other. The capabilities, as titled in this webinar, need to be wrapped around the person, the citizen's journey, rather than the profession. And this enables us to look at how new roles can emerge and how the gaps in the continuity journey can be addressed, or the duplications resolved. So we're looking for also a career framework that grows, retains and attracts staff, not just a capability framework. And this is the unique selling point. We need to attract, we need to recruit, and we need to retain all of our staff. And lastly, it's very much an outcomes approach, which means we're focusing on the actions expected in the workplace, informed by the knowledge, understanding, know-how, skills and evidence base that we all need to work from. Then the next slide, again, you'll be familiar with because it has informed our first series of webinars, the Venus framework, which again highlights the integration of these skills. And if we're going to embrace workforce development and transformation, all of these skills are important. So just to summarize, practice development for their values of person-centeredness and collaborative, inclusive, participative ways of working. The facilitation skill set, which we'll be touching on again today. The improvement and innovation skill set. The leadership skill set, and of course the culture change skill set, because without changing and addressing culture, nothing can happen. So the first case study, the next slide please, was started actually in about 2014, 2015 with funding from Health Education in England in Kent, Surrey and Sussex, and it culminated in the development of what was called the Assess, Treat and Sort framework for urgent and emergency care across the system. We were challenged, that was Carrie and myself and other colleagues, we were challenged to look at how you transform the workforce across the system for the benefit of urgent and emergency care. The next slide looks at the phases that were involved, but before that we've got the outcomes. So this first phase really identified the 3 enablers to workforce transformation, which we recognised and which all the stakeholders emphasised needed to be addressed. If we're going to start a journey of whole systems care, the workforce needs to address these 3 things. The first being clinical systems leadership. The clinical is really accentuating the role of clinical credibility. What I would translate that to now in today's language would be professional credibility from expertise in one's own profession. Secondly, the need for skilled facilitation, using the workplace as the main resource for learning, developing, improving, inquiry, knowledge translation, innovation and so on. And lastly, this one that we're focusing on today, about wrapping capabilities around the person across the system, not the profession. So the next slide please. So this work involved 3 phases at the beginning. The first phase was the stakeholder evaluation and gap analysis across the whole healthcare economy and system in relation to urgent and emergency care. And that led into the second phase, which comprised 2 parts: a Delphi study that generated international standards for integrated facilitation, and these have been taken up in Australia to inform leadership development. And the second part was the development of the whole systems capability framework across interdependent partners and career levels, and that embraced all the stakeholders from GPs through to community practitioners, to paramedics, to IC24, to all the social enterprises, as well as all the providers. So we looked at what the capability framework would look like. And then the third phase, which was anticipated in 2016, was a gap analysis. Now this never took place, and this was one of the challenges that we experienced. Whether it was difficult for the leaders at the time to envisage what a new approach to workforce transformation would look like, and therefore they were unable to see the value of that. We just don't know. So we did not achieve that gap analysis at that stage. However, we will hopefully achieve that when we come to the end of this presentation. So I wanted to flag that up as a real challenge, is helping others understand this approach in a way that is very innovative and requires sign up at the highest level of commissioner support. The next slide, please. So the Assess, Treat and Sort capabilities, the SORT stood for Support, Discharge, Organise and Admission, was the framing for the capability framework. And in that framework, we identified at every level of the NHS career framework and across every interdependent provider in the system, the capabilities that you would expect it, starting off from level 1 and 2 as in first response, right the way through to level 8 systems, consultant systems leaders. The next slide, please. So I mentioned that we use the NHS Skills for Health career framework. This is just an overview of the career framework, which guided the capability framework and what was expected, what capabilities were expected of each level of practitioner across the system. So 5, if you're unfamiliar with it, being registrant in any profession. 6, enhanced practice. It's now beginning to be understood as enhanced practice nationally. 7, advanced practice and 8 consultant practice, with our level 4 being associate practice and levels 2 and 3 as key way-ins through apprenticeships to progress people and to grow and retain them across the workforce. Now, one of the recommendations, as you remembered, that was made of the 3 was the need for clinical systems leadership. So in the next slide, I'm going to share with you a case study that was used based on experimenting with a consultant nurse who was an expert in the care of people with rheumatological conditions as a systems leader by moving her from an acute setting into a general practice. And the next slide summarizes some of the changes that were made to enable this to happen. So first of all, the organisation in which this happened already had developed a shared purpose framework for all our staff in terms of person-centred, safe and effective care, and a culture that supports those values. Then working with the rheumatology team, that included the rheumatologists as well as the nursing team at this stage, it did not include citizens. We generated the capability framework, and that informed the pathways for rheumatology across the system, particularly those 3 that have been identified on the left. And then through an approach that the local commissioners wanted, we worked with this concept of tiers of practice, which was looking at bringing care to as near to the person's home as possible through general practice-led care. And general practice does not just mean GP, it means all of the professions that are working together in general practice and what it is that they can do. Then tier 2 was a specialist virtual group of specialist practitioners from many professions who had expertise in caring for people and meeting their needs for rheumatology, and they could be virtual. So that's why we positioned this consultant practitioner in general practice to access that expertise and make it more accessible. And then the third tier was always seen to be a medical consultant led, because it was for the most complex care of people who could not be cared for in the other 2 tiers or required sophisticated diagnostics in hospital settings. So that was the background to positioning the consultant nurse, and it could have been a consultant physio, because equally we developed a consultant physio who undertook fantastic research as an embedded researcher in this field as well. So we did an informal evaluation of this role after 6 months. So I was responsible for undertaking the evaluation. And what was interesting was the impact that after a 6-month pilot that this role had as a systems leader, enabling and supporting others. The first thing that we were able to show was that patients who had not actually been outside of their house for years and years were able to increase their self-management, they reduced their drug use, they increased their mobility, and patient and family support. They were more confident because of patient and family support. There was a big impact, therefore, on patients and families, but there was also a big impact on the general practitioners themselves, who, knowing that they're very overworked, especially today, they actually loved this model. They loved it because they could access the expertise from somebody who could guide them about the specialist needs of people with rheumatology. And they were willing, as a result, to take on more work around blood monitoring away from the consultant nurse, so that the consultant nurse could use her expertise for greater benefit of people. And that was provided through the educational support that she was able to provide to general practice. Now, it's fair to say that the rheumatologists in secondary care were keen to provide peer review and support, but they were very cautious about these roles. They had a lack of appreciation about how either consultant practice or advanced practitioner roles can add to the quality of the service. They were really keen to focus on recruiting more rheumatologists, but were unable to do that. So there were implications from this pilot about how to activate person, the patient, the citizen, as an expert person in their own health, how to be innovative in advice and e-consultancy services, how to upskill GPs, and how to upskill community staff as well. So on to the next slide, we took forward the tiers approach then with up to 11 other clinical specialities, and we developed the approach so it was more sophisticated, included all of the stakeholders, including patients and charities, to develop a capability framework. And the capability framework built on the shared purposes that we had and complemented it. And at that stage, it appeared really complex, all the capabilities, there's subsets of performance indicators, there's subsets of knowledge and skills, and the evidence base. But that was because they looked, they were in a sort of manual format. So we then began to look at how could we make these capabilities more accessible. So we were guided by the Chartered Institute of Personnel Development on the next slide, who already had an IT facility on their website, which really aligned with what we were trying to do. So we kept at the core our shared purpose. We then translated what they used as core knowledge, core behaviours and core knowledge into these capabilities that we had identified for different client groups. And also you'll see at the front of this model is not just the purpose, but also the outcomes and impact that's being driven, the principles and the evidence base informing that, which echoed what we had done. So on to the next slide again, we were able to articulate that we had as an organisation and as a system, but the system didn't recognise it. That was the challenge. The core purposes, the generic capabilities across the NHS career framework for these 13 areas. We also have national capabilities that have been developed for multi-professional advanced practice and consultant practice, which would support the implementation and embeddedness of this approach. And then when we analysed, or when I analysed all these capabilities, they distilled down into 11 areas. So the next slide shows you first the shared purpose framework, which I alluded to, which was worked with a organisation and helped that organisation to keep at its purpose. But that again, that did not include everybody at the time that it was developed. It included all those that I could engage with. And then the next slide, in terms of the 10 tiers of care, which went on to be 13, the 12 capabilities that crossed all of them. And that's quite interesting, those 12 capabilities on the next slide. They are a little bit health orientated, but remember this was done some time ago. So we were able to distill all the capabilities wrapped around the citizen to be in these areas, and included all the holistic assessment that was required to enable people to cope with their health and social care needs. It demystified the contribution that every profession made, because we were looking at a holistic view of the capabilities, and then you could begin to think about where the gaps were. So that takes me to the end of that first and second case study. And now I'm going to enable Carrie, who's going to talk about another sort of element of this work about wrapping capabilities around citizens, from the work she's done with Marie Curie, which is a UK-wide charity working with end-of-life care.
Thanks very much, Kim, and I pre-recorded this because I didn't think I was going to be here, so here we go. Thank you, Kim. I'm now going to very briefly provide a summary of the Marie Curie UK Career Progression and Development Project. And this offers a slightly different approach to the examples that you've shared so far, because this is focused on a co-creation with practitioners across the country, focused on the knowledge, skills and know-how that they require to deliver person-centred, safe and effective palliative and end-of-life care, wrapped around the needs of the community and the people that they serve, that will help them to identify and action workforce gaps in systems and service needs. Thank you, Kim. The purpose of this 2-year project was to co-create a career progression and development framework with Marie Curie staff operating at levels 2 to 8 of practice across all care contexts, delivering person-centred, safe and effective palliative and end-of-life care. The intention of the project was to develop a draft framework, implement it and then evaluate it. And that framework was identified as having importance in terms of enabling us to identify the key knowledge, skills and know-how required of the workforce, the gaps in systems and service needs, the multi-professional team competences required, the recruitment and retention strategies that attended to role clarity, empowerment and support of the workforce that would enable both interprofessional working and the charity to adapt to the changing needs of society, and to identify strategies that would help to improve retention of its existing workforce and to recruit a future workforce offering a career pathway that was equitable to opportunities in the NHS. Across the 3 phases of the project, there was a longitudinal whole system approach with evaluation cycles that were monitoring and reporting developments to a steering group. In phase 1, we undertook 4 countrywide co-creation workshops with frontline practitioners. That resulted in the development of shared purpose, implementation and impact framework. And that framework identified 2 key domains and 9 capabilities with key performance indicators, knowledge, skills and know-how required of the entire workforce from level 2 to 8. That framework was tested out in a national conference held by Marie Curie in workshops with frontline practitioners. And then we reported back. In phase 2, the career capability framework, as it was called then, was submitted to short life working groups in Marie Curie, who examined it in great detail for each level of practice. And at the same time, we developed a self-assessment tool that would enable frontline practitioners to assess themselves against that career capability framework. We also produced a series of resources and instruction guidance for staff, and then piloted the career capability framework with 2 early adopter sites in hospice and community care settings in different parts of England. That enabled us to gather feedback from frontline practitioners about what worked and the areas in terms of language and levels of practice that required further adoption and adaptation. At that point in the career framework, not only did we have the knowledge, skills and know-how, but we'd also aligned the clinical skills required for each level of practice. And we explored with the steering group how we were going to align this to place-based strategies for developing new models of care for Marie Curie, as well as the learning and development strategies for the wider workforce to improve workforce recruitment and retention. At the end of phase 2, we identified with feedback from staff that the word capability, even though it was focused on growing the workforce, actually was less helpful, and so we agreed that we would call the framework a career progression and development framework. In phase 3, the career development and progression framework, as well as the self-assessment tool, were piloted in early adopter sites across England and Scotland, with opportunities for practitioners from Ireland and Wales to also join in. That was embedded within their annual appraisal, and early introduction to the framework was achieved through workshops held with staff, as well as education sessions. Those staff were enabled to utilise it and then use a claims, concerns and issues tool to feed back their experiences in order to improve language and levels of practice in terms of capabilities, knowledge and skills and know-how even further. So we made final adjustments to the language and levels based on the recommendations that practitioners made. Those recommendations were then reported back to the steering group for staff development, benchmarking and validating the tool, and then next stage of them embedding it across the organisation through staff development, training and education sessions, and linking it to other career progression frameworks for advanced and consultant practice. And we've now completed this and handed the project over to the project steering group. It's now being embedded in a new workforce development group that Marie Curie have created, and there is a plan to implement it in a phased approach across the 4 countries of the UK over the next 12 months. We're going to hear now from 2 of our colleagues, Audrey Rowe and Jeff Speed, about some of the challenges and celebrations that they want to share with you from the project, and also next phase of what it entails in terms of rolling it out across the entire organisation.
Hello, Audrey.
Hi there, Jeff.
Well, we're delighted to have this conversation today about our experiences of rolling out the Career and Capability Framework at Marie Curie. So I'm Jeff Speed, Head of Talent and Development.
And I'm Audrey Rowe. I'm one of the Associate Directors of Nursing and Quality.
So we've been asked to have a quick 5-minute conversation around 3 areas, which we're going to quickly try and pick up on. And the first one was what have been the highlights of rolling out this initiative. Without putting you on the spot, Audrey, what's one of your highlights?
I think because we've used that like a co-production approach, so we've really involved the frontline staff and worked with them very much in a collegiate way for them to help us, create the framework together and really help getting them to tell us, what matters to them and what skills and qualities and knowledge and know-how are needed to deliver that really high quality care for people who need that care and support at the end of life, and specialist palliative care as well. So I think that's been really rewarding, and to see the staff commitment and their passion for what they do, and that commitment and passion hasn't wavered throughout the whole project, because it's been quite a long-term project. So it's been really rewarding to see that.
I'd echo that. I think that you can see that passion in the project group as well, the working group that has overseen the project as well. That passion is there as well, and maybe some traditional silos have been broken down by us all working together and cross-pollinating ideas and how this project can move forward as well. And the fact that it's going to be owned by the workforce, by the staff, they've created it, so they'll recognise it. It is a kind of a bottom-up approach, where it's not going to be seen as an initiative which is being done to people, but something which the workforce own basically and will embrace as it's rolled out as well, we hope. So I guess there's still going to be challenges moving forward as well. Off the top of my head, capacity, of course, is always going to be an issue as well. I think that's going to be there. There's an element of change fatigue and exhaustion across the organisation, so we need to be careful around timing, about how we roll out and when we roll out, just do it in a very graduated form and process and not go with a big bang approach. What about you, Audrey, from a challenge point of view? Anything to add to that?
I think just throughout the project, particularly in the last 2 years, there's been a challenge of sustaining the project throughout the pandemic and the impact that's had on our staff and our ability to keep sustaining our services, which we've worked really hard to do. So I think as we move through the end of what we hope will be the end of the pandemic, I think it's important to recognise the importance of that and the impact of that on the workforce as well. And what we've seen is that the retention and recruitment is a big concern. So that's something we need to take into consideration as we move forward. But one of the things that we hope the career framework will do is it will help us to retain staff and grow our own. So it gives the opportunity for a healthcare assistant to hopefully be able to move through the different levels and go forward to do an apprenticeship, and then to ultimately, if they want to go forward and do their nurse registration training, that's our aspiration, that staff can see that they can join our organisation and progress all the way through to become a registered professional. Yes, I think there are challenges. There have been challenges. And I guess going forward, it's about how do we sustain that enthusiasm and that commitment. And as you know, as you've pointed out, Jeff, it's about making sure that we use a phased approach as we have throughout the first 3 phases of the project to the implementation, you know, identifying where you know, there might be issues with resourcing and capacity, and make sure we build that in going forward.
And I'd add to that as well that we have the right development that underpins the framework as well. Otherwise, it's kind of built on sand if we can't point to things like you talked about apprenticeships, and I'm thinking about other vocational qualifications in the devolved nations as well, moving into more senior level development programs as well, and also a perspective which supports some of the non-technical aspects of the roles as they evolve as well, things around leadership and management, change management, those kind of things. So it's a challenge will be ensuring we have the right investment in our development programs, and that we put the resources where they need to go as well. So we have a really exciting prospectus of development opportunities. So staff can see the competencies, but also can see, hey, it's okay, it's underpinned by these programs that you can access to help you get to there. So to access that as well. So that's really key. And I guess the challenge will be, as you say, a phased rollout, but both those areas need to go hand in hand, basically. We can't roll out and not have anything supporting the competencies as well. Otherwise, people are going to look around and think, how do I do this as well? So, and just to, you know, as we roll out as well, I think you're right, just putting together a business case which can understand what sort of investment is needed and where it needs to be addressed as well is quite key.
And I think also learning, you know, we talked about that in our project group yesterday, about the fact that our project groups is almost a community of practice, and how well that's worked. And that's one of the strategies that we're going to use in that rollout going forward, with the different staff groups and different places and different areas of our organisation, and use those communities of practice for staff to come together. And you know, that can include like a community of practice for managers as well, to understand, you know, what's worked well, what's been a concern, you know, what's an issue, what do we need to learn from that, what do we need to look at. So it's going to be a very much a kind of test and learn approach, and an agile approach, as we've used throughout the project, and it's learning what's worked well and taking that forward, really.
There'll probably never be a point, will there, where we'll just stop and, you know, light a cigar and say, all done, works perfect. Continually keep reviewing it and learning and adjusting. I bet you that the what it looks like when we go live will look very different to what it is going to look like in 4 or 5 years time. Yeah, we'll look back and smile at the naivety of what we were trying to do now compared to a mature framework in 4 or 5 years as well. And so yeah. I guess that's a challenge, but that's also that's exciting as well. So I think it's going to evolve, but there won't be a point where we'll just say job done.
And I think just that, obviously, just to bring in as well around the fact that we're moving to very much a place-based integrated approach to how we deliver our services, that's going to be crucial to understand what each place needs, and the needs of the population and the needs of the people that live in that place, to make sure we tailor the services that we deliver to meet those needs. And also the framework is going to be key to make sure our staff have got the knowledge and skills to be able to support those people too going forward. As we know, care is becoming more complex, more people are wanting to stay in the community, and that's the drive forward. So that's going to help us to do that and support more people.
That's a great place to stop there, Audrey, on that point. So thank you very much. It's been great to have this brief chat.
Quick bit of sound on that, please, Bianca. This project has been conducted across 2 years of a global pandemic, and it really has been a testament to the determination, dedication and creative thinking of all of the frontline practitioners and leaders who've been involved in this project across the 4 countries of Marie Curie UK, to overcome some of those challenges. And we've done that together. And here is just a couple of excerpts from our colleagues who've been operating in place-based teams across the country, who've been involved in the project across the 2 years. And I'd also just like to thank my colleagues, Professor Kim Manley and Dr. Lynn Ferber, for their support of this project. I think it's probably one of the most influential and successful projects that I personally have been involved in the last couple of years of my career. And of course, it is a project that has spanned 2 universities in terms of delivery. So thank you, everybody.
Thank you, Carrie, and also to all our colleagues at Marie Curie who have worked so hard collaboratively to make this possible. And then just moving on to the last case study, please, on the next slide. Thank you, Bianca. I think it's heartening to say that the context has become more receptive now to these sort of approaches. So we want to end with this last case study before looking at the priorities for the future. The last case study we were commissioned to undertake by Health Education England, East of England, to support the development of capability and services for people with eye conditions who need eye care or potentially do. And so we undertook our usual activities of co-creation with all the key stakeholders, but this time we needed to do it virtually rather than face-to-face, which was always a challenge. And just to share with you then the co-created purpose that the stakeholders wished the services across the systems to provide. On the next slide, please. So this was based on what mattered to them, that the ultimate purpose of care and services to people that's across the lifespan experiencing the eye condition is to preserve and maximise each person's sight, and going on to look at the reducing the organisational boundaries to improve continuity and using the multi-professional workforce, developing the competencies and quality placements to support service delivery. Then that fed also into the workshops we've undertaken with them, 3 in all, fed into the development of an implementation and impact framework, which is on the next slide at the top level. And again, if there is interest in the process that we've used to do this, we're very pleased to share with you that first report, which describes it in depth. So the next slide, please, Bianca. Focuses on the implementation impact framework. There's a lot more detail underneath this, but it's just the top level headings. Again, learning from the lessons of the past, the importance of identifying the enablers at every level, the importance of identifying the outcomes and the impact so we can demonstrate improvement, and then the sorts of processes that need to be there in the system to support care that's near to the person's home. The next slide shows you where we are at now. So at the top you've got the capability framework wrapped around the person. So you've got public health and screening and signposting, which is where the person would first come into contact with healthcare needs to do with eyes, and also the first point of contact in the community, triage and so on, through to the holistic ongoing care and recovery of people and the system's leadership for ongoing quality. And then you've got at the heart of this framework the person and their families. That's what it's all about. And then around it, the different teams that would be working together and the capabilities that go with that under community and general practice eye care, the multi-professional specialist eye care, working in community hubs, and then the complex treatments and interventions that might be required within a tertiary setting. The next slide, please. And then the sorts of clinicians who would be contributing to that. Whether one is a technician, a patient navigator, whether one's an ophthalmic surgeon, a community nurse, a GP and so on, optometrists and so on. Everybody's got a contribution to make. And the next slide, please, really takes us now to the last couple of slides about the priorities. So the priorities now are for enabling new ways of working and new roles to meet demand and retain and grow staff. And that requires systems leaders with the facilitation skills and the clinical expertise to facilitate and implement this across systems. It's dependent on co-production, as you've heard, and the integrated care systems need to establish these key multi-professional consultant practitioner posts to enable the implementation, embedding and evaluation of what needs to be done. The next slide is a reiteration of that facilitation expertise, what systems leaders would need to do to enable learning cultures, enabling staff to grow and develop, enabling services and capabilities to be evaluated across the system, and a focus on the impact and benefits and what matters to people. So the last slide looks at the immediate priorities now that we have. So Health Education England, next slide Bianca please. Health Education England have prioritised the 3 areas. There's a previous slide, sorry Bianca, it's probably a bit delayed in action, thank you. The Health Education England have prioritised these 3 areas: learning disabilities and autism, musculoskeletal and cancer, because of the long waiting times there are for NHS input, and we were asked to focus on that in terms of multi-professional consultant practice. And then you have on the right hand side the real priorities of the published integrated care systems that are coming into play in the next month: improving the health of children and young people, staying well and independent, helping people with preventable conditions, the long-term conditions or mental health issues, the multiple needs of population aged adults, and getting care as quickly as possible. All of those lend themselves to single capability frameworks that interact with each other across the system, and systems leaders working together to develop, embed and evaluate the care that's provided. So that takes us to the last slide. I know we've hardly got any time, and we've probably got about 3 minutes for any key points to be made before we then share with you the final webinar of the series. So please, Carrie, Sally and Jonathan, I don't know whether any key issues have come up. We have answered a couple as we've gone along, from Andrew, who asked about whether the CQC shared purposes were the same as we alluded to, and also flagged up the issue about agenda for change. I picked that up. I think it's fair to say we've stayed away from agenda for change. As soon as you start talking about agenda for change, it gets very controversial, it gets very polarized. And so we've stuck with the career framework. So the career framework is what's expected at each level, and it does relate to agenda for change, but we really wanted to get the journey right for citizens first, and then work with the job reviewers and so on at a later date about the implications for agenda for change. Don't know whether Carrie wants to add anything, or my colleagues, Jonathan with his history and commissioning, and Sally in terms of that point as well.
I think it really helped to, as you say, stop people thinking from a siloed perspective. It really seemed to galvanise people to think differently and much more holistically. So certainly in the projects that we've been involved in together, and still seems to really resonate in terms of projects that we're doing at the minute.
And I think, as you said, Kim, this has got such potential for the changing landscape of integrated care, and what, where and how new roles, new capabilities and competencies might be required, particularly looking at the new apprenticeship support roles coming into health and social care systems as a workforce, and where and how they can be their talents can be maximised. And I think this work really showcases the need to, I think it was one of your colleagues said, really wrap it around the citizens, makes a big difference, rather than the agenda for change or the professional groupings. It's about what's needed for our populations that has allowed this work to take shape and function. I'm very aware of the time. I'm sure lots of people may need to be moving on. If you do have any further questions, do put them in the chat, and we'll try and get Kim and Carrie to answer those at a later point. Jonathan, would you like to tell us a little bit about the next webinar due in 12th of July?
That's right, Sally. So hello, everyone. Yes, our next webinar is on Tuesday, the 12th of July. And the focus of the webinar is growing workforce capacity and capabilities for system leadership. We've got a great lineup of speakers for that webinar. So we've got representation from the Caribbean Nurses and Midwifery Association, Health Education East of England, Norfolk and Waveney Integrated Care System, and colleagues from the James Paget University Hospitals NHS Foundation Trust, all who will be showcasing really great work around developing system leadership. We'll be looking at system leadership through the lens and different perspectives of system leadership. So we're describing it as a prism, and our focus will be very much around sort of embracing and focusing around sort of integrated care and integrated care system leadership. We look forward to seeing you then.
Thank you everyone for sticking with us. This has been recorded, and all of you that logged on to Eventbrite will be sent the YouTube link so you can watch it again, because there was a lot of information in there for people to understand and probably want to refer back to. So thank you, Kim. Thank you, Carrie, our participants who joined as video contributions to the webinar, and we look forward to Jonathan and Co.'s webinar in July. Thank you, everyone.